Welcome back to Ask Dr. Mingle. It's great to see you again. I am Dr. Dan Mingle, family physician, founder, and CEO of Mingle Health. I'm here to answer your questions about value-based care and value-based payment. This year, I'm dividing the proposed rule content into 6 presentations. The first presentation in the set is just an orientation to the rulemaking cycle and introduction to other resources where you can read more, learn more about the proposed rules. Second is rules specific to MIPS and alternative payment models. Second is rules proposed for MIPS value pathways. This program, the fourth program, is about proposals for the Medicare Shared Savings Program. Another will be about proposals for a new ambulatory specialty model as a alternative payment model through the Centers for Medicare and Medicaid Innovation. And finally, I'll list some of Medicare's requests for information in case you're interested in browsing and submitting some comments to Medicare in answer to their questions. In this session, I'll be commenting on Medicare's proposals for the Medicare Shared Savings Program. First, sharing the current pertinent numbers for participation in the MSSP, new expectations for progressing through risk, introducing some extra leniency on the 5,000 beneficiaries target, proposal to retire the health equity bonus, proposal to change assignment and eligibility rules, some changes to the APP Plus measure sets, expansion on the extreme and uncontrollable circumstances policy, and some policies around change of ownership. First, facts about the Shared Savings Program as of the January 1st of the 2025 performance year. There are 477 ACOs, including about 15,000 tax ID number practices, 650,000 providers and suppliers, 11.2 million patients. There seems to be great progress into full risk. Back in 2018, only 18% of ACOs were in a two-sided model. For the year 2025, 71% of ACOs are in a two-sided model, that is with both upside risk and shared losses if there are losses. As far as use of ECQMs or MIPS CQMs to do the APP, in 2021, there were 12 ACOs. 2022, there are 37, and 2023, there are 73 ACOs that moved off of the Medicare web interface. Now, regarding advancement through risk, a couple of years ago, they expanded the number of years that an ACO could be in a one-sided model. Now they're proposing to roll that back again. An inexperienced ACO in their first participation period may choose to be in a one-sided model for all 5 years. They can advance into higher levels of risks in the basic track in those first 5 years. They can move into enhanced if they move quickly, but they won't be permitted under this proposal, if finalized. They won't be permitted to go back into a one-sided model in the second and subsequent participation periods. They can stay in the basic track as long as they wish, although in periods after the first, they're limited to the level E, which is a two-sided model within the basic track. And experienced ACOs may choose to stay indefinitely at level E in the basic track or advance into the enhanced track. Now, there are, as part of the leniency they're trying to build into eligibility, they found that they can deal with ACOs with fewer than 5,000 assigned beneficiaries, particularly if they've fallen temporarily below 5,000. But in those who have had fewer than 5,000 during the first or second benchmark years, they will be prohibited from going beyond the leveling of the basic track, basically to avoid excessive losses to Medicare based on a smaller statistical sample and potential more random variation in performance. So when entering into a new agreement period, they propose to keep a requirement of 5,000 beneficiaries in year 3 of the benchmark period. But if they're below 5,000 in either or both the first or second benchmark years, they can participate, but only in the basic track. There's a cap on shared savings and losses to prevent losses to Medicare based on performance that varies randomly rather than due to the cause. And they propose to exclude those practices from participating in some of the policies for higher shared savings in low revenue ACOs. Medicare is proposing to remove the health equity bonus, which has been and they in fact would like to do that retroactively, ending it as of the 2025 performance year. So practices have come into this year expecting the 2025 health equity bonus. But if this rule finalizes, they won't have access to that. The purpose of that bonus has been for organizations that move to MIPS CQMs or ECQMs. They can get extra points for a higher proportion of their practice that is disadvantaged. And this is to encourage them to use MIPS CQMs or ECQMs and not use Medicare CQMs or for prior years staying in the Medicare web interface. This is part of the overall plan in this administration to expunge all mention of health equity and disparities from the rules. In this case, they're saying they don't need it because they already have the complex organization adjustment that's encouraging practices to advance into into ECQMs and all payer, all patient reporting. And they also have the alternative quality standard to do that. I'm a lukewarm on the policy. I think it's good to reward practices for advancing into these more demanding levels of reporting. The complex organization adjustment is obviously planned to expire once everyone's on ECQMs, and the alternative quality standard likewise anticipated to end when Medicare CQMs is no longer an option. I think it is good to continue to reward people for taking care of disadvantaged populations. It's hard to profit in a healthcare practice with a higher proportion of disadvantaged people, more poorly insured. And this problem won't go away, and there's clear evidence and a good body of knowledge that to help keep these populations healthy, they need better access to health care. And the health equity bonus is something that could continue beyond those years that we're trying to incentivize all patient, all payer reporting and ECQMs. Medicare is proposing some adjustment to the assignment and eligibility criteria and methods for patients eligible for Medicare to be a Medicare beneficiary in for use as Medicare CQMs. They're proposing that These are patients with Medicare Part B who have one or more primary care services in the performance year with a primary care specialist, the expanded set of specialists. Um, and the link, the notation in the rules is included here. Um, I think this is a good change. It means that patients that come into to a healthcare organization for specialty services uh, who therefore have codes that will qualify them for these measures, but they don't have the care or the data uh, to measure the performance because their primary care is received elsewhere. I think this is good for ACOs. They're also proposing to revise the primary care services list. To add behavioral health integration add-on codes, psychiatric collaboration care add-on codes, and suggesting they eliminate administration of the social determinants of health assessment tools, uh, which I disagree with. I don't think this is a good idea. It is clearly a solid primary care service to assess the needs of an individual, particularly those social determinants of health, which are shown to have a significant effect on development of disease, control of disease, care for disease in affected individuals. I don't see any justification for removing these services from the list of eligible primary care services. Some proposed adjustments to the APP Plus measure set. I prepared this table to help understand where we are with that. The Medicare CQMs scheduled to continue through the 2027 performance year. I think likely to continue beyond. The rule is silent on that. Measures are otherwise remaining much the same. They're doubling down on the plan to add the Measure 305 engagement in substance use disorder treatment. It's now more solidly planned to begin in the 2027 performance year. Adult immunizations intended to be started in the 2028 performance year, but it's very dependent on having specifications written for the measure as ECQMs, which currently don't exist. And probably the biggest proposed change to eliminate the screening for social drivers of health. I think this is the most controversial of the proposals. I hesitate to complain about any measure being removed from the set. I think every administration has the right to set its own priorities, including this. I'm a little bit more concerned about actually removing the measure itself from the list of possibilities for MIPS. But as far as using it in the APP Plus, go for it. There's a proposal to expand the exceptional and unavoidable circumstances policies for ACOs. ACOs in general have not been permitted to submit most EUC applications. There's still quite a number they can't, that only the subsidiary participating practices can apply for EUC exceptions. But they are expanding for quality and financial performance, particularly in the wake of cyber attacks that have affected several ACOs. So they propose to permit EUC applications from ACOs when 20% of their beneficiaries are in an affected area or when the parent organization is in the affected area. It still requires qualifying submissions, but scoring is protected, giving the better of what's submitted or a neutral score, for keeping you from going into a loss range. Change of ownership. they've noted that sometimes an ownership change leads to a tax ID change, which makes an experienced ACO look like an inexperienced ACO and removes some benchmark figures. So they're proposing some ways of continuing some continuity when there's a new TIN that's applied to an established practice, and while there's change of ownership, but I don't see any way that would hurt. I think that would help the participants and the group of it. So remember, the proposed rule is all about soliciting comments. What do you like? What don't you like? This is your time to make those comments. Medicare listens. The final rule always has some adjustments based on what we've told them. I recommend submitting your comment through the Federal Register. The link here on this page is where you will view the proposed rule for 2026. And at the top of the page, there's that green box that says submit a public comment. Click on it, enter your comment in the box, and submit. I suggest one comment at a time. Tell them what you're commenting on, what your comment is, close the box, reopen it if you have a second comment to submit. I think it just keeps it clean, makes it make sure that your comments don't confuse the reviewers, and potentially some of them get lost. So watch for the final rule to be released in the Federal Register on or about November 1st. And then access the current state of the rules in the Electronic Code of Federal Regulations. Thank you for joining us today. Use the links here on the right to ask questions, correct my answers, contribute your experience and comments. We can be smarter together.